For the next hour and a half, we're going to cover diseases of the GI tract. What basically I'm going to start doing is looking at the actual different components of the GI system, including the esophagus, stomach, gastric diseases, duodenal diseases, small, large bowel diseases, and talk about pancreatic diseases. We sort of covered the liver last week, okay, and the gallbladder system last week. If you look at the stomach, or the GI tract, the way you want to look at the disease process is you want to look at anatomically. It's one way of doing it. You can see problems like within the lumen, endothelial lining diseases, which are like Crohn's disease. Then we'll have medial disease processes that are actually affecting the smooth muscle, including peristaltic diseases, like Hirschsprung's disease. Then you have aneurysmal disease problems where the actual vasculature begins to either aneurysm or becomes bleeding into the lumen. And then you have blood vessel diseases where you get lack of blood perfusion to the GI tract, which can cause very severe complications and death in patients. We see this very frequently here because of the age of the population that we're dealing with. First one, let's look at esophagus. So we're going to go from the inner portion and moving out. For the esophagus, the inner portion, one of the problems that we encounter frequently in cancer patients is a problem called esophagitis. It's actually caused by esophageal erosions. What you're seeing here is Candida. Okay, this is the candidiasis. This is an immunosuppressed individual which either has received high doses of antibiotics or doesn't have a proper immune system, didn't have proper flora that's maintained in his esophagus. This is an extremely painful process, and people will come in with severe dysphagia, which is inability to swallow properly, and we'll do an upper endoscopy on these individuals to diagnose it. Okay? You can also get esophageal erosions and inflammations from things like injuries, from eating fish bones, which is very frequently seen. We had a little 3-year-old kid that we did the other day that she's swallowed a fish bone, and it was actually embedded in the back of her tongue. And then we had another young lady, about 6 years old, a few months ago, that was embedded in the esophagus. The problem with these kind of injuries is that if it penetrates all the way through the esophagus and it goes into the mediastinal structures, the mortality rate is almost 90%. So you have to get these bones out because they don't just come out by themselves. Okay? The other thing that you'll see frequently, too, in the older age population is you see pills. Potassium is specifically... These are very dangerous cases for you, okay? Because they require, every time you do them, rapid sequence induction and intubation. One of our students that graduated out of this program did not listen to this lecture, did not remember that, and she decided to sedate somebody, and the patient died. 26-year-old woman. Okay, so if you don't think it's dangerous, this job, you better think again. Foreign bodies inside the esophagus will fill up with secretions, and as well as gastric content will be below it. One of the things that you can always tell that somebody has something stuck in their esophagus is they will present with a bag, usually, or a basin, and they're constantly spitting into it because they can't swallow their own secretions. They'll be constantly burping. They're bringing this stuff up. And the other thing that you'll see is that the person will have severe hypertension and usually tachycardia. So it's really obvious that somebody is in pretty much distress. If you don't see those signs, then it's not likely that the esophagus will still have material inside of it. The person can still feel irritated because if it's a bone or something that cut through them a little bit, okay, but it's still uncomfortable. But that person has at that point passed the material if they're not hypertensive and they're not having those kind of signs. So sometimes it's appropriate to give these people a little bit of fluids to make sure that it's cleared. Now, the other thing that you have foreign bodies in the esophagus will be common in little kids will be coins. These are potentially, again, bad news because if the coin comes up, it can go into the trachea and cause complete obstruction. You get esophageal spasms that occur, but specifically the sympathetic stimulation is very significant. Okay? If you aspirate, if you take care of somebody like this, you got to make sure that you do the Selleck maneuver, which is cricoid pressure. If you see the food start coming up, okay, the first thing you do is do not make sure that the person's head's not up before you put them to sleep. Okay, keep them flat. And some people will teach you to put the head up. The only problem with doing the head up is if the food content does come up, it's going to go down the lungs immediately. So that's the downside to it. If you have the person flat, if the stuff starts coming up, you have a few seconds. But you have seconds, not long. You must immediately react by, if the person is vomiting actively, you have to release the Sellic. Okay? If you don't release the cricoid pressure when somebody's actively vomiting, okay? In other words, the muscle relaxant hasn't kicked in and the person's starting to retch before the muscle relaxant's kicked in, you got to let go. If you don't let go, the esophagus will actually rupture. You can generate up to 300 millimeters of mercury pressure by vomiting. So if you occlude the airway, or occlude the esophagus, you can significantly rupture the esophagus, which would be a devastating complication. So anyways, the first thing you want to do is, if the person is just passively vomiting, then apply cricoid pressure immediately and continue cricoid pressure. Clear the mouth. Okay, usually we'll suction it. And one of the things that a lot of students forget is they'll have their suction ready, but they'll still have it in the bag. This is when seconds really matter. If you have it in the bag, the first thing will happen is you'll pull it out, and then it'll still be stuck in the bag. And then you're fighting it. You don't have that time. So make sure that when you start these kind of cases, you have your Yankauer suction out of the bag and underneath the pillow so you can grab it rapidly. Okay? This happened to me the other day. I mean, I was working by myself. I didn't want to call anybody in. I was working with the nurse in the actual endo suite, and as soon as we put the patient to sleep, she had cricoid pressure on her just fine, but it passively started coming up. So suctioned him, intubated him, okay, and you put the cuff up at that point. Now here's the trick. Don't ventilate. Why don't ventilate? Because if it's passive, now the stuff is just sitting in the trachea. So you put a special suction down, which you should also have available, down the trachea, suction it out, and then you pull it out, and then you can ventilate. Now you've cleared the airway out, and you're fine. Okay? Will some material possibly get down there? Yeah, but usually it's not going to be a problem. Most people that are drunk, and you can see them in their vehicles, okay, they will be, every once in a while they'll vomit, and they'll aspirate, but they don't die, okay, because they have some airway reflexes. But there has been reported cases of people in the back of somebody's car that are completely drunk. They vomit into their mouth and they suffocate and die. So that can happen. And the same thing happens with these kind of situations when you're putting these people to sleep. So the Yankauer is actually built to suction the person properly. Understand how the Yankauer is set up. Please don't just put it in the back here. That doesn't do the job. You've got it. It's actually built to actually touch the trachea. So you put it all the way in and you suction the airway and you go lateral to make sure that you sweep and get all the material out of the way. So this is the actual device that you use to actually suction into the trachea. Okay, try to keep it in that kind of situation. Just you have gloves on, so it's not, but do it quickly. Now, what happens if you have problems around the structure, which is a stricture? Stricture is the etiology is from chronic, usually esophageal reflux disease. You can also have an injury from prior foreign body, okay? Or very commonly in the older days, one of the things that people would try to do to commit suicide is that they would swallow lye. And as a consequence, people would get esophageal strictures that we would have to go in quite often to dilate. Usually you have to do this almost every 6 months for this individual for many, many years, and then eventually sometimes it resolves, or sometimes it doesn't, and it gets worse. These people are always at high risk of aspiration because the contents stay above it. This is a great study here showing you the actual barium that they've given this individual, and you can see that it's literally stuck, all this fluid is stuck above it. So even if somebody tells you, well, I haven't had anything to eat for 24 hours, there's still a possibility that these people could have liquid inside their esophagus. So they're at very high risk for aspirating as well. The way you pick up that this person still most likely has fluid in there is when they talk to you, you want to step back about 3 feet, okay? Because they have so much severe halitosis. That's important information to you, okay? If you have somebody with halitosis, the first thing I look at is I tell them open their mouth, okay? Because I want to look at their teeth. If their teeth are not rotting, then that rotting smell is coming from somewhere. That most likely is coming from the esophagus. So you could have a Zenker's diverticulum, which I'll show you here in a minute, where you have a pouch, okay, or you have something like this, like a stricture, and these people you better intubate as well with a rapid sequence. Most people with esophageal strictures have a lot of chest pain or abdominal pain on swallowing, so usually it's another thing that you'll pick up on. If you get on to the next disease, you have what's called peptic esophagitis, which we usually call Barrett's esophagus. Okay? Basically, it's a constant reflux problem due to your gastric esophageal reflux disease. Okay? It also indicates to you that you have lower esophageal tone. It leads to erosions of the endothelial medial wall. Okay? And there's a much increased risk for developing esophageal cancer, which is a big concern. That's one of the reasons that we've developed H2 blockers as well as other agents that we use to decrease the gastric acidity. Now, it's associated with several disease processes, especially collagen vascular diseases such as scleroderma, dermatomyositis, polymyositis. It's also associated with alcohol consumption, nicotine, obesity, diabetes, and basically if patients are taking in large meals. What you see here is a nice picture of what Barrett's esophagus looks like. Okay, these are erosions, okay, and eventually this chronic irritation causes these individuals to develop cancer. Now, the other thing that's also associated with Barrett's esophagitis is a high degree of asthma, okay, because what you have in these individuals is you have chronic aspiration syndromes that can take place. So that's another concern that you may have. Hiatal hernia is something that you it's a good test question they're asking you all the time. It's associated with reflux. Okay, it's a compromised junction of the diaphragm to the esophagus and the stomach. And what happens in this situation in the hiatal hernia is that the actual stomach begins to slide through the diaphragmatic wall into the actual mediastinal structures. The problem with it is that you have two kinds of hiatal hernias. You have the one that's the herniated portion into the stomach, which is this, okay, and then the much more serious one is this one, okay, which is the paraesophageal type. The sliding type is very much what you see in older age groups, okay. Do you still have an increased risk of aspiration? Absolutely, but this one is much more concerning because you can have a large amount of food content in there to cause problems. What you see with lower esophageal tone, things that can actually significantly change it and decrease the actual tone and make the situation worse are things like atropine and glycopyrrolate, okay? Tricyclic antidepressants, patients that are on dopamine agonists, and also GABA agonists, such as barbiturates, propofol, benzodiazepines. All those decrease the actual tone to the lower esophageal tone, which increases the risk for aspiration. Now, the next concept is esophageal diverticuli. These are basically outpouchings that occur due to the actual structural wall becomes weakened, or people are actually born with this. Okay? Zenker's is a very concerning one because it occurs in the upper esophagus, and you can have food that can be stuck in there for up to a week or so. Okay? So even if the person tells you that they haven't eaten anything, it doesn't mean anything. Now, the other thing that's a problem with Zenker's is that it's questionable if cricoid pressure even works. Some people say that you shouldn't even apply cricoid pressure, so it depends on who the author is. The problem with that is that if you don't apply cricoid pressure and the person aspirates, everybody's going to bury you. So I would recommend you just apply cricoid pressure. It may not work. That's the thing you got to keep in the back of your mind. So you got to make sure you have your suction ready to go, and that's the best you can do sometimes. You can also have a traction diverticuli, which is further down here. Usually it's from the actual esophagus getting scarred down to something and sort of holds in place, and then it's called a traction diverticuli. And then you have the epiphrenic, okay, which is the low esophagus, which is down here. It's very similar to a hiatal hernia, the paraesophageal type. It's hard to differentiate it. The reason it's different is because usually this lower esophageal sphincter is below that, and it appears normal in these individuals. Although I can tell you this would be pretty difficult to diagnose. And you can see this is what the outpouching looks like when you do it with endoscopic procedures. You see the main pathway down to the stomach, and this is where the actual pouch is at. You can have people that have also diffuse esophageal spasm disease, and these are another high-risk group for aspiration. Okay? Almost all these things that I'm talking about, you should really consider doing rapid sequence intubations on these individuals, even if you're doing endoscopies, because a lot of times food is stuck in this kind of esophagus. You can actually get muscle hypertrophy. You get non-peristaltic contractions. You can all sorts of kind of things. What you usually get is patients complain of severe pain, and you can see this kind of corkscrew pattern inside this esophagus. This is not normal. It should be smooth going all the way down. This is very uncomfortable. Some people actually respond to nitrates, and other people also get calcium channel blockers that seem to work. Achalasia is one of the ones that you really have to intubate. That's one that it seems like everybody misses in the book. Okay? Achalasia means basically loss of peristalsis of the lower two-thirds of the esophagus. So the esophagus just becomes a big pouch full of food, and it has nowhere to go. Because there's no peristaltic activity, people don't even feel uncomfortable. Okay? They just feel like a fullness, but it doesn't jump out at them. It's the spasm that makes the pain come. So with this kind of disease, you don't get that kind of level of discomfort. Okay? The other problem is that you get a chronically increased lower esophageal tone, and the lower esophageal sphincter does not relax during swallowing. What these people do actually is they get up from dinner, and they usually will walk around, and they usually hop. Okay? You may think it's kind of weird. You see them in a restaurant, and you go like, what is that person doing? And then you realize they have achalasia, and they're trying to get their food down into their stomach. Okay? The aspiration risk is actually very high because of residual food in the esophagus, so you really have to secure the airway in these individuals. Don't get fooled into being talked into somebody. If they tell you, well, this person has achalasia, they'll be fine with just sedation. No, this one needs to be intubated. I've had arguments with GI guys, and sure enough, when you get down there, there's food there. You've got a big problem in your hands. Now we're going into the stomach. The gastric anatomy is kind of important in the sense that you have to know that it's composed of the fundus, which is the top portion here. Then you have the actual body of the actual stomach. And then you have the actual pyloric entrance. And you have gastric folds inside the stomach, which increase the surface area and increase the acid production levels. And the stomach is very important for peristalsis. Most people, when they eat, they clear their stomach usually in about 35 to 50 minutes. Okay? So you're going to be doing a lot of these endoscopies, and you get pretty quickly comfortable with seeing what a normal stomach looks like. This is what a normal stomach looks like. You can see the nice gastric folds. And then you see somebody who has gastritis. You can see how the gastric folds sort of disappeared, and then you have pretty much a redness that you see all over the place. This is the pylorus at the end of the stomach that you'll be doing quite a number of cases because you'll see a lot of people with ulcers here. The endothelial layer of the stomach is very important for production of gastric acid. It produces a pH as low as 2.0, which is pretty caustic, as you can imagine. And the actual amount of volume that's being produced is pretty constant, usually around 25 cc's of gastric acid per hour. Most people clear this stuff, and it's usually have residual 5 to 10 cc's in most individuals. The actual mucus secretion protects the outer lining from this low pH, so these mucus glands are also critically important for producing this kind of protective layer over the stomach wall. Things that will attack that mucus secretion will be drugs that we administer, medications, especially like aspirin. So people on chronic aspirin usage will actually break down the mucus secretion, and as a consequence, the person will get erosions and get gastritis. What you'll see is these gastric pits will release large amounts of the hydrochloric acid. They also waste a lot of potassium through here, so if a person begins to vomit, you'll see that potassium will be wasted significantly in these individuals. The hydrochloric acid production has been produced by parietal cells that are actively transported into the stomach. The hydrochloric acid converts things like pepsinogen into pepsin, and that's important for breaking down proteins. Hydrochloric acid also breaks down connective tissue, so you can imagine if you didn't have that mucosal surface area, it would actually kill the gastric lining fairly easily. One of the things that the hydrochloric acid does is it basically neutralizes microorganisms before they get into your GI tract. So essentially, that's a good thing. The reason that we have that in our system is because we're omnivores. Okay? We eat anything that comes in our mouth. We don't care. Okay? If we can pick up a piece of food off the ground in the old days, we'd think nothing of it. Okay? Now we're all sorts of clean and stuff, but we'd pick up anything. Okay? A cow's stomach has a very high pH. okay, versus a human stomach has a very low pH. Cows actually like bacteria. The bacteria actually help ferment and break down the grass that they're eating. So if you make a stomach of a cow acidic, you'd kill off so much of the bacteria that their stomach couldn't process the grass. So that's why we can't eat grass. It doesn't do anything for us. Okay, we can't break the cellular compound inside the grass. So instead we eat the cows. Vagus stimulation has multiple effects in the gastric acid secretion. Okay, if you think about it, the vagus would make kind of sense that it increases hydrogen ion production because it's the portion that's important for controlling when you eat. The endoprophrin-like cells activated are leading to histamine release, leading to increase in hydrogen production via proton pumps. Then the D cells activation leads to inhibition of acid production by release of somatostatin, okay, which is the paracrine gland, which we're not going to talk about this. I skipped the neuroendocrine discussion on these lectures because you're already having that in another class. And then the G cell activation leads to increased gastrin release, which then increases hydrogen ion production via proton pumps. And that's why we use proton pump inhibitors, because they actually shut down this gastrin release. Now, don't go into all the pathway. I drew this for you to make it a little bit easier for you to understand what the vagus system, how it actually activates these different components. The reason it's sort of nice to look at this when you get a little more time, I'm not going to really ask you questions on this in the exam, you've got enough to learn, is that the proton pump inhibitors can shut down these kind of gastrin release and things like that. So in that case, it is important. But you also have COX-2 inhibitors that also begin to affect, which is in a negative fashion, this, and actually causes problems. So what you see here is a continuous kind of pathway being produced of hydrochloric acid from parietal cells. These actually break down pepsinogen into pepsin. Okay? Hydrochloric acid then activates through an ulcer histamine release, and then it causes an increase in hydrochloric acid production. So this kind of situation of ulcer formation is aggravated by things that are endogenously being produced by the stomach. You have other things that will also affect the stomach production, things like CCK and secretin. Okay, these are actually can actually inhibit hydrochloric acid and pepsinogen secretion, and they also decrease stomach motility. This is a way of a negative feedback mechanism to shut off the acid production. Now, if you don't control acid production, what you end up having is peptic ulcer disease. It occurs in about 10% of patients, men during their lifetime, and about 4% of women during their lifetime. So some men seem to have a higher predilection to it. Recurrence is common once you develop peptic ulcer disease, and these people usually develop abdominal pain. You eventually, if you cause enough of erosion to take place, you get bleeding, what we call hematemesis, which is blood in the vomit. And you have, if the person is chronically bleeding and they're not really vomiting, eventually their stool will turn black, which we call coffee ground emesis for vomiting that's been sitting there in the blood for a while in your stomach. But after a while, the stool turns black, and we call it melena. Okay? Everybody knows what it smells like. You can tell somebody's GI bleed from usually across the room. So perforation and free air can be eventually a problem that we end up having to deal with in the operating room. Pathophysiology of peptic ulcer disease basically is that you get things like bile salts, aspirin, alcohol, ischemia. Those are that thing that causes the damage to the mucosal wall. This causes a decrease in function of the mucosal wall, which doesn't produce a mucous membrane properly. Eventually causes the actual back diffusion of acids into the gastric mucosa, which then converts more pepsinogen into pepsin, and this leads to an increase in ulceration in these individuals. Eventually, you get formation and liberation of histamine, which increases the acid production and causes local vasodilation, which increases the actual capillary permeability and causes damage. So it's really a self-fulfilling disease process. Once it gets started, it's hard for it to shut down. There's types of peptic ulcer disease, and what's really fascinating is that many of these peptic ulcer diseases are due to an infection. When I was taught, this was unknown. I mean, we all thought it was just ulcer produced by acid. But actually a lot of people that are getting peptic ulcer disease is due to an infection called H. pylori. And you'll hear that the endoscopist is doing the endoscopy, and you'll say, I'm doing a biopsy for H. pylori, and that's what they're talking about. They're just making sure that the person doesn't have it. If you do have this, you can be treated with antibiotics, and then usually the peptic ulcer disease will disappear. Medications-wise, it also can cause peptic ulcer disease are non-steroidal anti-inflammatories and anticoagulants such as aspirin, warfarin, and thrombolytics. All those can actually cause increased risk of peptic ulcer disease. There's also other reasons why people develop peptic ulcer disease. It's usually due to overproduction of acid, such as a gastrinoma. These are gastrin-secreting tumors, which increase hydrochloric acid production, histamine production, and these lead to ulcerations and diarrhea. You have the other famous one, which is called ZE syndrome, or Zollinger-Ellison syndrome. It's associated with what's called MEN1, which is multiple endocrine neoplasias 1. Metastasis usually is very evident in these people, and you get gastric hypersecretion. These people develop a full kind of stomach feeling, and they get diarrhea, and they develop usually hypokalemic metabolic alkalosis. So ZE syndrome is actually something that you might have to know for your boards, because it's one of those weird ones. It's associated with another disease process. Stress ulcers are also a major problem that we deal with, and certain kinds of illnesses increase the risk of developing this. We didn't really understand what the main mechanism is of that, but now we're starting to understand that it's usually due to low perfusion states. So things that affect perfusion to the stomach lining are usually what eventually causes these kind of problems. So the number one of these is called Cushing's ulcers. Cushing, from the famous man that worked on brain neurosurgery, called, I don't remember his first name, but his name is Dr. Cushing. So they named it after that because what they found was a lot of people that had brain injuries also had an associated increased incidence of duodenal ulcers. Okay? So that's due to the stress levels of the brain shunting away blood flow to the GI tract and preferentially to the brain. And then the mucosal parietal cells can't protect themselves properly, and it causes the damage and ulceration. The other one that also causes a significant amount of fluid shifts was associated with severe burns, called Curling's ulcers. The way I remember it's curls is imagine that you're toasting something up, and what happens to the outer surface of anything you're burning? It curls. So that's how I remember Curling's as burns. Okay? So that's associated with severe burns. This is what a gastric ulcer looks like. Okay? That's actually a fairly benign one. Okay? What you're seeing is that you're seeing scar tissue developing around the edges, okay? And it's trying to protect itself by trying to cover it. The problem with this is usually, the reason that we usually get called in is that it gets deeper, okay? It erodes into a blood vessel, and the person starts squirting blood. You can significantly lose a lot of blood volume from this. So bleeding is a big issue, volume depletion. The other thing that's a big problem is that you have to consider in the back of your mind that this person's a full stomach. Okay? You always have to keep that in the back of your head. Please don't take endoscopies lightly. Okay? They're very dangerous procedures. I think it's the highest risk place in the hospital. Okay? It's even higher risk than almost any other place. Okay? The reason being is we're coming into situations where people are telling us, oh, the person's fine, fine, fine. Then you find out that the guy's a full stomach, has small bowel obstruction that's been misdiagnosed. You put these people to sedation, and all of a sudden you got vomiting coming up. And aspiration can kill pretty easily. Perforation can also be a very significant complication. Okay? It's usually a coexisting disease, and about 10% of them may actually also have malignancy associated with it. And then you can have obstruction, which can cause full stomachs. Usually you have to do a surgical repair that can be pretty extensive in this kind of situation, and that can be pretty high risk. Treatment is usually antacids. Antacids are two kinds, particulate and non-particulate. You don't want to give particulate antacids to individuals if you're going to put them to sleep. Okay? You want to give the non-particulate type. There's actually different kinds that you can get. Sodium potassium bicarbonate, which is Alka-Seltzer, sodium citrate, or monosodium citrate and citric acid, which we call Bicitra. The one that does actually the best job is actually Alka-Seltzer, which is cheap. Okay? But guess one which we use Bicitra. Okay? Some people actually say that it's particulate, but it isn't. Alka-Seltzer is actually a non-particulate compound. Some people also give bismuth salicylate, which is kaopectate or Pepto-Bismol. And then also, if you're having the H. pylori, you treat it with antibiotics such as flagyl, tetracyclines, and amoxicillin. What decreases hydrochloric acid production? This is where I expect you to know for the test, is things that are vagal antagonists. Okay? So things like anticholinergics or vagotomy are common treatment plans, especially vagotomy, which means we actually cut the vagus nerve to the stomach. We have to cut both sides, so it is an extensive surgery. There's some problems associated with it because it causes a decrease in peristalsis. But usually the GI tract recovers after that. The other thing that we commonly use used to be H2 blockers, famotidine, which is Pepcid, Tagamet. Tagamet was usually the one that we use more extensively. Now we're going more to Pepcid, okay, because it's has a little bit less of a platelet inhibition effects. So Pepcid is the preferred choice at this point. There's also proton pump inhibitors, which is the most classic of this, is omeprazole, which is Prilosec. Omeprazole does a great job of inhibiting the proton pumps, so you don't get the production of hydrochloric acid. It's much more potent than H2 blockers. Then you also have gastrin inhibitors that are coming into the market. They're still not readily available, so we're not using those. So the ones that you want to pay attention to more for the exam is the omeprazole and the famotidine and how they actually work. Somatostatin is something that also is used extensively to decrease acid production. Pretty strong stuff, as you can imagine. It's given in IV drips. There's some downsides to it. It can cause some hypotension if given too high of doses, so you got to be careful with it. Agents that neutralize acid, like antacids, are sometimes used, but usually that's over the counter, and patients are doing that to self-medicate. Intestinal disease is the next subject matter. You have inflammatory diseases, you have obstructive diseases, tumors, infectious, peristaltic disease, and malabsorption problems. The inflammatory bowel diseases are things like this that you're going to encounter, which is ulcerative colitis. Ulcerative colitis involves just the mucosa only, and usually involves only the colon and rectum, so it does not involve the small bowel, which is good. Complications of this is that you can get toxic megacolon, which is the actual lining gets so inflamed that it's no longer peristalsing, and then the colon just starts getting larger and larger and larger. As you can imagine, that's not really healthy. You also get malignant degeneration, so there's an increased risk of cancers in these individuals. And eventually, because the actual lining gets so dilated, they can get perforation. You can also get, it's a lot of these inflammatory bowel diseases, you get a lot of psychological problems associated with it. You get anxiety disorders. We're not exactly sure why that is. Most likely it's because of production of certain compounds by the GI tract wall that's causing some of these issues. There's also increased incidence of arthritis, fatty liver, and what we call pericholangitis. Surgical treatment is either a proctocolectomy, which means you remove this area, or an ileostomy with pull-through, which is curative. But it can be, these are pretty daunting procedures, to say the least. This is what a toxic megacolon looks like. It shows you how big the abdomen will get. Okay? It's actually a very serious complication. And this is what the colon looks like when they removed it. Okay? So this is not a joke. You guys you're going to see this. It's not going to be something that you're not going to encounter. And this can be lethal. Then you have what actually the ulcerative colitis looks like in the gross specimen. This is definitely looks not, should show you a normal one. But this is a grossly abnormal. You see the ulcerations and pseudopolyps that you see in islands and normal mucosa. So it's a pretty extensive disease that pretty much knocks out the colon. The other colonic disease is the Crohn's disease. Involves all layers transmurally. It does get into the small bowel, though, unfortunately, which makes this a much more difficult disease to control. Affects the ileum, which is the distal portion of the small bowel, colon and rectum. But if you're lucky, maybe isolate just the colon, or maybe isolates the small bowel. The extraintestinal manifestations include arthritis and what's called an iritis, which is on the eye. 28% occurrence in surgery after 5 years. The bad thing about this is that you can't seem to get rid of it. Complications of this process, because it causes a banding effect, is it causes complete obstruction of the actual GI tract. It can cause significant contritional complications as well. B12 deficiencies become an issue in these individuals. And unfortunately with Crohn's, it will go transmurally and it becomes fistulized. They'll attach to other organ systems. I've seen Crohn's disease fistulized to the vaginal wall, to the bladder, to the uterus, or else into other small bowels. So it connects up to other places. So it can become difficult to take care of. And it'll actually fistulaze to the skin as well. You'll start getting drainage of stool to the skin. So pretty significant complications. You can also develop fissures, perirectal abscesses. You'll get significant malabsorption, just like in the other one that we were just talking about. And then you also may develop stones because of calcium oxalate overproduction. This is what Crohn's disease actually looks like. You can see transmural inflammation in the small and large intestine. And you can see these kind of, looks like a cobbled street. Okay? And when you get in there, you can see how red it is. This a lot of times bleeds. So these people have anemias that are usually a problem to deal with as well. There is several drugs that actually seem to work. These are anti-inflammatory drugs. The most common one is mesalamine. It's a substance that helps control inflammation. And you also have sulfasalazine, which is an aspirin derivative, which of course increases the risk of bleeding. You have things like Remicade that blocks the body's inflammatory response. And then you have cortisone and steroids, which are also immunosuppressives. The immune system suppressors can be actually very potent, such as 6-mercaptopurine, which can cause other problems, which is bacterial overgrowth. Okay? So sometimes you have to give these people antibiotics to treat the bacterial overgrowth in the small intestine, which is causing strictures, fistulas prior to surgery. Antidiarrheal and fluid replacement therapy is very critical in these individuals. You've got to keep up with your fluids. You can be at very hypotensive on induction in these people because of that. All right, next, pyloric stenosis. This happens in an age group that's usually young, usually found in children. Once you grow into adulthood, there's very few cases of pyloric stenosis. It'll mimic something called what we call gastric outlet syndrome, which is similar to pyloric stenosis, but it's a different etiology. Usually, gastric outlet syndrome is usually due from prior peptic ulcer disease, and you get scarification. But it basically does the same thing as pyloric stenosis. It causes obstruction of the actual stomach emptying. As a consequence, you get gastric distension, and these people are at very high risk for aspiration. Pyloric stenosis is not a surgical emergency. It is a medical emergency. I have to say that one more time. Pyloric stenosis is not a surgical emergency. It is a medical emergency. So these kids should never be done at 3 o'clock in the morning. It is not appropriate. And you need to replace their electrolytes, get them stabilized, and then take them to the operating room in a controlled fashion. You want to make sure that this kid gets an NG tube put in, okay, to empty their stomach, if you can. Okay, I've seen people aspirate from this. These are not the ones that you want to do a volatile induction on. These are the ones that you're going to do a rapid sequence on and intubate them very quickly. Okay? In the old days, they would tell us to do these kids awake and intubate them awake. Problem with that is, you can imagine how much trauma that is. It increases intracranial pressure, and the kids may actually bleed into their brain. So maybe it's not such a great idea. The problem is, if you aspirate and you have a ton of fluid content in the stomach, the kid could die on you. And that's a pretty devastating complication all itself. The actual medical treatment is actually fairly simple, but you really have to have a good surgeon doing this. This is not a surgeon that does it every once in a while. You should have a surgeon that does it all the time. Okay? If it's your kid, and that's how I look at it. If it was my kid, I would not have anybody in this area do it. Okay? We'd have to go to Miami or maybe Fort Myers, where they have pediatric specialists up there. It would be fine. But nowhere in this town I would have anything done like this to my kid. There's not enough surgeons that are doing this. They're not pediatric specialists. And it's very simple because all you have to do is cut the outer lining, cut a little bit of the muscle, and the procedure takes 15 to 20 minutes when it's done by somebody competent and knows what he's doing. If you have somebody who's not, and they cut too deep, now you have a perforation, much more difficult to deal with. If you also cut too deep, then the actual pyloric wall will not work properly, and you get other problems as well. So you really do want to make sure that the surgeon knows how to do a proper pyloromyotomy. There's also tumors inside the GI tract that are called carcinoid tumors. These are very rare, thank goodness, but they're tumors caused by enterochromatin cells. They're usually of GI or pulmonary origin, and they secrete high levels of serotonin, histamine, kallikreins, prostaglandins, and all these other things. What you'll see is carcinoid tumors can be found almost anywhere. Sometimes we'll find in the ileocecal tract, which is what you see here. Carcinoid tumors usually develop symptoms after they metastasize from the liver. And the question is why? Because these tumors actually secrete hormones, okay? But they're usually secreting it into a venous system. As it goes to the liver processes and breaks down these hormones, so the person doesn't become symptomatic. So it's only until the liver is infiltrated with metastatic process, and then it goes beyond that's when the person becomes symptomatic. So a lot of these carcinoid tumors, you find them late, which is bad. Okay? You see 20% reach systemic circulation, and a lot of times the way the symptoms are is the person will get symptomatic diarrhea, it's constant, okay? And also they'll get sudden flushing from the histamine release, and they'll get also hypotensive. So you get flushing from the kinins and histamines, diarrhea from the serotonins and prostaglandins. In heart disease, you'll get right-sided fibrosis from things, and especially you get tricuspid regurg and pulmonary stenosis possibly, and you'll get SVT. This is due to serotonin and to the actual metastatic process may actually enter into the heart. You may also get bronchoconstriction from the serotonin, bradykinin, and substance P, and you may actually get hypotension from the kinins and histamine. So carcinoid gives you this kind of weird symptomatology. Once you start seeing these kind of flushing, anytime you start seeing flushing in anybody or hypotension that sort of happens randomly, you got to think some kind of tumor that's secreting this stuff. And carcinoid tumors are pretty common in that sense. You get hypertension at times as well, which can be from serotonin. People also get these kind of weird symptoms like abdominal pain for no reason. They appear to be small bowel obstructions, and they can be due to small bowel obstructions from the carcinoid tumor actually growing into them. You get also hepatomegaly from the actual metastatic infiltration of the liver. Eventually, when the liver can't process sugars properly, the patient develops hyperglycemia. And they also develop hypoalbuminemia because, again, the liver can't produce the proteins. So may also develop niacin deficiency and pellagra-like lesions, which we'll talk about in the next hour and a half or so. Agents associated with carcinoid crisis are things like that may actually provoke the mediated release, are things like succinylcholine, which is worrisome for us. Okay, but if you have to decide which one is going to be, if you have a full stomach and succinylcholine is not really contraindicated, we have to realize that when you give succinylcholine, it may cause the actual release of the compound, but it's not essentially contraindicated. If you look at it, almost all the muscle relaxants are contraindicated to a certain degree. The ones that you could use would be the aminosteroidals, such as vecuronium, in that family group, but all the benzoisoquinolones seem to aggravate the situation because they increase in histamine release. So all these agents, mivacurium, atracurium, and D2-bicurari, all benzoisoquinolones, which all of them release eventually histamine in certain degrees. Epinephrine and norepinephrine can also, and dopamine, all your essential catecholamines, can aggravate the situation and also activate the stuff. Things that we know that don't cause release of mediators, things like diprovan and etomidate, again, vecuronium, cisatracurium. I would take issue with that because it's also benzoisoquinolone. I think it just wasn't studied extensively enough. This one releases the least amount of histamine of all the benzoisoquinolones, but I still think it would be a mediator, and I'd stay away from it if at all possible. All the inhalational agents seem to be safe, and it seems like somebody put in there for Desferrine may be a better choice because of liver metastasis. Carcinoid tumors can release high amounts of vasoactive peptides. It's called a somatostatin analog called octreotide, and also antihistamines are used as a possible treatment path. Anesthesia-wise, you want to continue your octreotide to prevent the release of the vasoactive peptides. And the antihistamines are good to use to avoid histamine-releasing drugs. So things like, Benadryl, would be a good choice in these kind of situations. Remember that Benadryl's also got sedating qualities to it. The catecholamines, serotonin or kallikrein, just be careful with them. Intraoperative carcinoid crisis may occur if the surgeon is touching the tumor, so you get severe bronchospasm and hypotension, but you want to avoid epinephrine in this situation and use actually octreotide, which was one of those important points in this discussion. So if you encounter a tumor such as carcinoid tumor, you really need to make sure that you read up on this case again before you start it, so you don't get into problems by adding epinephrine to somebody who develops hypotension. You may also get delayed emergence due to high serotonin levels, which actually suppresses the central nervous system. So I'll stop here, give you guys a 10-minute break, and we'll start back up on colon cancers.